basically 4 knee ligaments that we reconstruct. There's the anterior cruciate ligament. There's the posterior cruciate ligament. Anterior cruciate ligament is what you hear mostly about. Posterior cruciate ligament, most of the time, if there's not significant instability, you don't have to reconstruct that. If there is significant instability, you can reconstruct that, and utilizing the similar grafts that we talked about previously. Allograft meaning tissue from somebody else, and can use autograft. Mostly with PCLs, they actually use allograft, because the grafts are longer, and the tunnels are longer for the posterior cruciate ligament reconstruction. The medial collateral ligament, hardly ever reconstruct that anymore. Years ago, there was a dog study, and basically they cut the ligament, let them run around, and they braced them, let them move the knee, put them in cast, and they operated on them and surgically repaired them. The ones that did the best, the ones that were in braces and were able to move their knee, their ligaments were stronger, and they returned to normal much faster. So then we started doing that in people, found out that's the one ligament in their knee that will actually reconstruct itself. So very rarely do we have to do anything to the medial collateral ligament. Lateral collateral ligament, if that's torn, you want to get on that fast, because you can repair it directly if it is torn. If not, then you have to reconstruct it. And there's certain other aspects to if the lateral collateral ligament is torn. You have what's called a posterior lateral corner, which is the back side on the outside of the knee can be torn. There's a lot of structures back there. You can fix those acutely, and you get a very good result. If you wait several months and try to go back in, then you have to do reconstructive procedures, and they're not quite as good in the long term as actually if you reconstructed that primarily with the person's own tissue.